Good morning, everybody. Let's join. We're just waiting on one or two more people so that we can have a quorum and then we will get started. And it looks like one of those individuals just joined. So welcome, Dr. Hart.
Good morning.
All right. I think I'll keep an eye out for Dr. Marshall, but I think we're good to go ahead and get started. OMPP, are you all ready?
Yes.
Okay, just a quick couple of reminders. This line is being recorded, so just take that into account. And if you could please mute your line when you're not speaking so that we can eliminate some background noise, but please don't mute my line. I'm in there now as Brayton, so that is our line here, so please don't mute us. I will help drive the agenda and defer to Dr. Ott as we get to things. And then just a reminder, we will do roll call voting. You can aye, nay, or abstain, and we'll go through the list when we get to that voting. I did also want to make an announcement that we have a new board member, Dr. Gupta, and she's here in person. The rest of y'all are slacking when the new member shows up in person, just saying. But Dr. Gupta, if you would like to introduce yourself, that would be fantastic.
Absolutely. I'm Dr. Sameta Gupta. I'm a PhD health economist at IU in Indianapolis. I am an associate professor and I have been at IU for 15 years, so it's a bit. My research is primarily in 3 domains. It's access to health insurance. So I do a lot of work on Medicaid access. I also do work on prescribing of controlled substances. That is something that's been of interest to me, and behavioral responses of prescribers to state policies. And I also do a lot of rural-urban differences in access to care. So that's a little bit about me, and I teach a lot as well. So.
Awesome. Welcome. All of your topics sound very pertinent to us, so I think you're going to get a lot of information here as well that hopefully will be helpful for you. All right. With that, I will turn it over to you, Dr. Ott, to call us to order.
Thank you, everyone, for being here. I am remote, and I appreciate that everyone else is too, because it's really cold outside and it's going to snow up here. So, so there are actually extenuating circumstances. So I'll open this January 2026 DUR board meeting and hand it back to OMPP.
Thank you. Opening comments for OMPP. I did see that John is on, but I don't know if, so John, were you wanting to provide comments or did you want Ann to? At least he was on. He is on.
Well, I can go ahead and do it.
He's muted, so why don't you go ahead?
All right. So, good morning. I'm Ann Kuhn. I'm one of the pharmacists with the Office of Medicaid Policy and Planning. I also would like to welcome you, and with this being the first meeting of 2026, Happy New Year. I did want to make mention that effective January 1st, NDY's ended participation as a managed care plan option for our Healthy Indiana Plan and Hoosier HealthWise members. Members that were enrolled in MDYs have now transitioned to Anthem Care Source or MHS Managed Health Services. There have been multiple bulletins published regarding the transition, and I direct folks to those for more details.
Thank you. Next on the agenda, we have approval of the minutes from our last meeting, which would have been in November.
Is there a motion to approve?
Motion to approve.
Sorry, Beth.
Hi.
Second.
All right, I have a motion and a second. Dr. Ott.
Aye.
So Dr. Gupta, you're next in the roll call, but you can abstain if you would. You certainly can say whatever, but you can abstain if you would like, since you were not at the last meeting.
I think I'll stay.
Okay, perfect. Dr. Hart.
Aye.
I don't think I see Dr. Marshall yet. So Dr. McCarty.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Abstain.
So that still should pass, I think. So we've got 2 abstentions and the rest are ayes. So that motion will carry. Thank you. Just making some notes. All right, I'm going to go rogue. I have one item that's not on the agenda today that we typically do in January, and that is the voting for the officers of 2026. So Carol has been the current chair, and then Dr. Marshall was the vice chair.
Dr. Treadwell.
Or Dr. Treadwell was the vice chair. My apologies. So I think historically, Dr. Treadwell goes into the chair position. Should the board like to vote on that? And then we need to vote on who would go into the vice chair position. But certainly if Dr. Treadwell doesn't want to be in the chair, there's others that do, we can open it up for that. So I would open it up for motions for the chair this year.
Do
This
we
is-
first want to ask Dr. Treadwell if she
If
wants
she wants
to?
to. Yeah, that's,
I'm okay.
so this is Beth. I make a motion for Dr. Treadwell to move into the chair position.
I second.
All right, we have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta. Perfect. Dr. Hart,
Aye.
Dr. Marshall's not here. Dr. McCarty,
Aye.
Dr. Treadwell.
You're on mute. I think I should abstain, so.
That's okay. I can put you down as an abstention. And then Dr. Williams.
Aye.
Perfect. So we have all ayes and one abstention. So congratulations, Dr. Treadwell. You will be our new chair for 2026.
Yay.
All right. If I can take a motion then for our vice chair for 2026.
I make a motion, Carol Ott.
Dr. Ott, are you willing to accept the vice chair nomination?
Sure, I'm happy to do that.
All right, I'll second.
Kelly.
Any,
Unless Kelly,
other
are you dying
nominations
to do it?
I was going to nominate Dr. McCarty, so.
I
can
need
have
to
a
be more
runoff vote.
experienced. I need another year under my belt.
any other nominations or are we good? All right. So I have a motion and a second for Dr. Ott. Dr. Ott.
I'm going to abstain.
Okay. Dr. Gupta.
Aye.
Dr. Hart.
Aye.
Way too
That was-
enthusiastic.
I was gonna say that was very, very enthusiastic. Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes and one abstention, so that motion carries. Congratulations, Dr. Ott, on your vice chair. I'll leave it up to you all since I started with you in chair for this meeting. Do you want to continue for the rest of the meeting and have Dr. Treadwell go start in February, or Dr. Treadwell, do you want to just take the bull by the horns today?
I can wait till February.
That's fine. We can do that.
All right, sounds good. We will do that. So let's move on then into some of our presentation. So we do have stats from November and December since we didn't meet in December and present those November stats. And for our new board member, I'll try and keep you as current as I can or how we put these stats together. And I won't focus as much on November since the December is more current. But overall, for total PA stats on the fee-for-service side, we had just a little over 19,000 approved and then just shy of 5,000 that were denied. And then we separate this out further by what we call point of sale quick check, which is our automated PA system. So it reviews criteria automated. And we had 84% approved there, 16% denied. And then of those that were denied in the automated system, 26% then go in and get an actual manual PA where the doctor sends a PA in directly. And then of those, 78% were approved and 22% were denied. And often the vast majority of these are approved because it usually is the case that we're just missing a piece of information that's delayed, like medical claims information, et cetera. So that gets delayed when that comes over. So that's usually where we see that difference. On the clinical call center side, this is just strictly manual PAs, those things that only come in manually from the prescriber. And so we had 47% approved here and 53% denied. And then when we look at our top 10 for the automated PA system, point of sale quick check, we had stimulants, clonidine, guanfacine, and opiates. Usually our top 4 with the antipsychotics are all kind of there. Sometimes they flip around a little bit and who's in the second and third position, but in general, stimulants are typically at the top. And then on the manual PA side, we had the GLP-1s in the top early refills and then Wegovy and Zepbound, which has been fairly consistent now for the past several months that we've had those, since those have been on the manual PA side, that those have been there. So then switching gears a little bit to December, we had a little over 20,000 approved and then just shy of 6,000 denied. So a little increase in January or in December, which isn't surprising because we did slow down a little bit in November. On the point of sale quick check side, we had 80% approved and 20% denied. Of those that were denied, 22% went to the call center, where 78% were approved and 22% were denied. And then on the manual PA side, we had 57% approved and 43% denied, which you might be saying, that seems to be kind of a significant flip from what it was last month, and it is. And so I'm going to skip point of sale quick check for a second and just go to the manual PA side, and you'll notice that the early refills are in the top spot and it's significantly higher. And so you might be saying to yourself, why is that? And that is because we had a system update, if you will, on the way that the stats are being collected. So historically, we were receiving these reports for early refills from our member services call center, because that's who puts the early refills in. And they, in their previous system, they were tracking it per member. So they could have put in 10 overrides for one member, but we were only counting it as one. Now in the system, we are pulling all the overrides that are placed, since we feel like that's likely more accurate, and we would like to count all the overrides. And really the reason that most of these are coming through, and I think where we're seeing the higher numbers, is in the long-term care. So as individuals, they're either admitted or discharged for long-term care, and they're either going home or they're coming into the long-term care facility. A lot of times they either had home meds or they had LTC meds that were filled, and then they're a refill too soon for their other meds when they're going in or out. And so they get overrides for those meds. And since they're often elderly and they're on multiple medications, we're seeing much higher numbers there. So we do expect this to kind of be relatively consistent as we go forward with this new methodology, but just wanted to point that out, that's why this is higher in this round and likely to stay higher there. We still have the GLP-1s kind of in the top group there, and Wegovy and Zepbound is in 4, but continues to escalate. Laxatives and cathartics it's always in the top group, but it does tend to cycle just based on the PAs. So like if somebody had a 6-month or 1-year PA, then they kind of come through at around the same time. And so we see them escalate a little bit as well. Any questions on that before I go back to the point of sale quick check? All right, so for the point of sale quick check then for December, again, stimulants in the top spot, clonidine, guanfacine, and opiates, and then antipsychotics in 4. So pretty consistent with where we've been overall. And then when we look at our overall trending graph for the whole year, you can see really relatively consistent. There is that slight uptick in December. And again, we had significantly more early refills in there, as well as just some overall more PAs in general in December, because November did kind of go down just slightly. I think likely due to the Thanksgiving holiday, we tend to see it go down. And we do also tend to see people go and get more meds in December in case they feel like if their coverage is ending in January or something like that. We just tend to see more people go out and get some medicine and supplies, et cetera, in the December timeframe. Any questions or comments on that before we go into the opioids? All right, so we also have November and December here, and I'm going to focus more on December, but we did have decreases in November. As I mentioned, we kind of had overall claims decreases in November. The kiddos maintained around the same day supply as well as number. And then Here's our trending graph. I'll take a little more time of December for this just because I think December is the more current and explain some of these. And then here's December. So again, we even decreased a little bit from November, which had decreased. So we're kind of on a little bit of a downward trend, which is not really surprising when we think about there's less elective surgeries in November and December. People are out for the holidays. So we just tend to see less opioid use during that time. Again, our kiddos are at 319. They're right around 4.7 days. We like to make sure that the kids are less than 5 days. So we're always consistently typically under that 5-day mark and kind of oscillate a little bit in there. So the chart to the right is showing the number of utilizers that we have that fall into which MME bracket. So the vast majority of our patients are falling into the less than 90, which is what we like to see. The PA exempt is the number of individuals that have either a diagnosis of cancer, sickle cell, or some other end-of-life palliative care diagnosis. So they're not required to meet that PA. So you can see that our members that are 500 and above are all exempt. We don't have anybody that's not exempt in that group. And I should have looked at this. 300, we're at 300 as of January 1, right? I think is when we changed. So 300 MME is where we're at. Just for Dr. Gupta, you may have known this already, but we started at 1,000. So it was quite high that we started. So we've made a lot of progress. We've been working our way down bit by bit. And so we're now down to 300. So we're making good progress with the goal to eventually get into the 90 to 120 range. We are going to start probably here pretty soon, slowing our tapers down even more just because we're getting into those lower ranges and we try to not do any more than 10% at a time in our taper. All right, so here's the folks that are in the 90 and above group. We don't include the less than 90 just because they would totally skew this graph since the vast majority are in there. And we only put those members that are not exempt. So you can see kind of where people are falling. So again, nobody's in the greater than 500. We're currently working in the 250 to less than 500 range. So we still have a few people in there that we're kind of moving through, but we'll continue to work through that as we get into those lower doses. And then this is our overall kind of utilizer graph. So the green color there at the bottom is our current utilizers, those that have been using for greater than 90 days that are adults, so over 18. The cranberryish color in the middle is those that are considered new utilizers, so they've used less than 90 days of therapy. And then the purpley blue color at the top is our current utilizers that are kiddos, so the less than or equal to 18 age. And so you can see we had a period where we kind of were stepping up a little bit, and then now we're kind of on this step down again. And I think that's likely the case again of what we're seeing now may be more along those elective surgeries. People tend to have more elective surgeries over the summer versus like over the holidays, et cetera. So we just kind of may continually see this like step up a little bit and then step down a little bit. But overall, fairly consistent in general with where we are and have been for a while. So this is our less than 90 trending. And again, this really speaks to say like, when we see the less than 90 going up, it's usually because we're having a lot of procedures and surgeries and things like that, where they're getting kind of a short-term supply, less than 90 for a new utilizer. So November and December, and even October for that matter, we've really seen a decrease. And I think that's just because there's far less elective procedures during this time. And then here's all of the 90 and above trending. And you can see there is kind of that stepwise or slight decrease in the orange color there. That's the less than 500 to 250, which is what we would like to see since we're continuing to work our way down. So that's kind of what we would expect to see in that graph. Just a little bit of reminder here for these, they're very small numbers of patients. And so even just changing a couple patients can really skew how this graph looks. But overall, it's kind of trending in the way that we would expect it to trend and looking the way we would expect it to look. All right, any questions or comments on opioid reporting? All right, so we have some mental health quality advisory committee recommendations, but not in the utilization edits. So there were no new products that we had that we needed to add utilization edits to. But we did present some updates to the clonidine guanfacine PA rule. So Javadin is a clonidine solution and presented PA criteria to go in with the other clonidine guanfacine criteria. So They must have a diagnosis of hypertension and be 18 years of age and older, and then unable to swallow the tablet formulation. And they should not be using concurrently with guanfacine, or the prescriber has provided valid medical justification for the current use of clonidine and guanfacine. And then they must meet the utilization edits, which are presented down there below. So you can see the quantity limits and the max daily dose and the age. And then there's reauthorization criteria. So if they've been using for 90 of the past 120 days and they come in to get a renewal of their PA, again, validating that they're not able to swallow the tablet formulation, that they're still not using concurrently with guanfacine, or that they provided rationale as to why they are using concurrently. And that if they've been using concurrently, then we need to have some vitals provided, so we know that they're not having low blood pressure and heart rate and things that might be a side effect from using those two together. And then again, the same quantity limits and age limits that are there below. And then an update to the Spravato PA. So we updated the initial and reauthorization that the prescriber attests that the member has been counseled on the increased risk of sedation when they're using concomitantly with benzodiazepines. So just making sure that the prescriber has had that conversation. And that's all that we had for MHQAC to present. Any questions or comments on those? If not, if I could get a motion and a second for those, please.
So moved.
This is Beth, second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. And Dr. Gupta is really getting trial by fire today on her first meeting, because we also have therapeutics committee recommendations to go through. So she's getting to see it all, truly. So our therapeutics committee had recommendations at their December meeting. And so you might remember that we did kind of change the schedule a little bit, which is why you all didn't have a December meeting. And so we're back-to-back T committee presentations to you all. What I can tell you is this is far less than the previous one I presented, since mental health is not included in this one. So it should hopefully be far less painful than the last presentation was, with the amount of things we had. So we will start off with the respiratory recommendations. So there were no recommended changes in the classes that are listed here. For the antihistamine decongestant combinations and second generation antihistamines, the therapeutics committee recommended that the Clarinix prescription syrup be removed from the SUPDL because it's no longer manufactured in CMS terms. So we're going to remove their quantity limit and step therapy. And then the desloratadine solution, moving to non-preferred, and then adding the quantity limit and step therapy of 10 mils per day. And then they must have trialed both the cetirizine or loratadine within the past 90 days. And then the fexofenadine 30 milligram per 5 ml suspension, maintaining that on the OTC drug formulary and then adding to preferred under the liquid formulation category in this group. And then adding age limit and step therapy and updating their quantity limit. So the age limit is under 12 years of age or unable to swallow the tablet formulation with a max age of 18. Quantity limit of 30 mils per day. And then they must have a trial of both the cetirizine solution and loratadine solution within the past 90 days. And then just as a comment for Dr. Gupta, we try to have fairly standard language around the under 12 years of age for liquid formulations if there are like oral capsule or tablet formulations available. So either they're under that age or they're unable to swallow those formulations is kind of a consistent messaging that we put throughout the PDL. All right, and then the levocetirizine RX solution, maintaining its current preferred status and quantity limit, and then updating its step therapy to must have trial of both the cetirizine solution and the loratadine solution within the past 90 days. In the beta adrenergic and corticosteroids, the Breztri Aerosphere, maintaining its current non-preferred status, maintaining the class-specific quantity limit, and then updating its step therapy. They must have trialed and failed a neuroelliptotherapy for at least 90 of the past 120. And then the fluticasone salmeterol Respaclick. This is the Air Duo Respaclick authorized brand alternative, moving it to non-preferred and maintaining its class-specific quantity limit. And then for Trelegy Ellipta, moving to non-preferred and maintaining its step therapy and class-specific quantity limit. And then the ProAir Digihaler in the beta agonist short acting is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. In the leukotriene receptor antagonist, the brand Singular granules are no longer manufactured in CMS terms, so we need to remove that from the SUPDL as well. And then in the nasal antihistamines, nasal anti-inflammatories, Zatana is no longer manufactured, so we need to remove that from the SUPDL. In the oral inhaled glucocorticoids, the Arminair Digihaler is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. In the pulmonary antihypertensives, the Lycrev suspension, which is a sildenafil suspension, is no longer manufactured in CMS terms, so we need to remove that from the SUPDL as well as PA criteria, as well as the Revatio suspension. This is the brand only, so there is still sildenafil suspension available. It's just not these kind of branded formulations, so we just need to remove both of those. And then the Ventavis is also no longer manufactured in CMS terms, so we need to remove that as well. In the respiratory and allergy biologics, Tezspire, we're going to maintain its current preferred status, but update the PA criteria to include their age expansion. So now it'll be for those 12 years of age and older who have inadequately controlled chronic rhinosinusitis with nasal polyps. So just updating the age there based on their label. And that concludes the respiratory agents. Any questions, comments on the respiratory group? If not, if I could get a motion and a second for that therapeutic category, please.
Ms. Kelly, I move to approve.
Second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
Thank you. We have all ayes. That motion will carry. On to the anti-infective recommendations. The Therapeutics Committee has no recommended changes in the classes that are listed here. For the systemic antifungals, the diflucan brand tablet is no longer manufactured in CMS terms, so we need to remove that from the SUPDL, as well as the Noxafil brand tablet. Both of those are no longer manufactured in CMS termed. And that concludes the anti-infectives. Any questions or comments on those?
Move to approve.
Second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta,
Aye.
Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
Thank you. We have all ayes. That motion will carry. On to the cardiovascular. We have no recommended changes in the classes listed here. For the ACE inhibitors, Altace brand is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. In the angiotensin receptor blockers, Arbli is a losartan suspension, moving it to non-preferred and then adding step therapy that they must be unable to swallow the tablets. And that concludes the cardiovascular. Any questions, comments, concerns on those? If I could get a motion and a second then, please.
This is Beth. I make a motion.
Kelly, I'll second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart. I think that was an aye. Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. On to the lipotropics. The Therapeutics Committee has no recommended changes in the classes listed here. Within the lipotropics class itself, the Therapeutics Committee is recommending that Evkeeza be maintained in the non-preferred status, but updating the PA criteria to include the age expansion for those who are 1 year of age and older and have the hereditary familial hypercholesterolemia, the HoFH. And then for Lovaza, the brand only, removing that from the SUPDL because it is no longer manufactured and CMS termed. And that concludes our lipotropics. Any questions or concerns on those? If I could get a motion in a second then, please. I think that's Dr. Hart making a motion. We're getting some static when you say Dr. Hart. I'm not sure why.
I
don't
think
know.
you moved to approve.
Okay, I think we got at least a motion. Do I have a second?
Second.
All
Now,
right. Better. I think we could hear you better that time, Dr. Hart.
okay.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart. Maybe type in the chat. Aye. Okay, perfect. Dr. McCarty,
Aye, sorry.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. For the anti-migraine preparations for Ajovy, maintaining its current preferred status and quantity limits, but updating its PA criteria to include the indication expansion for preventative treatment of episodic migraine in pediatric patients who are 6 to 17 years of age and weighing 45 kilograms or more. So just adding that age and weight expansion. For the sumatriptan naproxen product, maintaining its current non-preferred status and quantity limit, and then adding step therapy for a trial and failure of at least one preferred rizatriptan and one preferred sumatriptan product, and medical justification for use of the naproxen sumatriptan. And go over here since I was clicked over there. For Symbravo, this is the meloxicam rizatriptan, maintaining its current non-preferred status and quantity limit, and then updating its step therapy for a trial and failure of the naproxen sumatriptan and medical justification for use of Symbravo. And then Trexamet, which was the sumatriptan naproxen, is no longer participating in the MDRP, so we have to remove them from the SUPDL and remove their quantity limit. And that concludes the anti-migraine agents. Any questions or comments on those? If not, if I could get a motion in a second then?
Ms. Kelly, I move to approve.
Is there a second from anyone?
Second from Pat.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart, I think he's back.
Aye. Can you hear me now?
Yes, much better, much better.
There we go.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. On to the electrolyte depleters. The Therapeutics Committee has no recommended changes for the electrolyte depleters, which concludes the electrolyte depleters class. Any questions or comments on that?
Move to
If
approve.
not, if I could get a motion in a second, please. Sorry, I think I cut you off, Dr. Treadwell. Did you motion?
That's okay. Move to approve.
Second.
All right, we have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta,
Aye.
Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. On to multiple sclerosis. For the cladribine, this is the generic Mavenclad, maintaining its current non-preferred status, PA, and quantity limits, but adding it to the generic medically necessary criteria, meaning that the brand Mavenclad is going to be more preferred, if you will, than the generic, even though they are both non-preferred. On the Copaxone 40 milligram per mil injection, moving to non-preferred, maintaining its current PA and quantity limits, and then removing it from the preferred brand drug list, so it will no longer be brand preferred. Or the Xtavia, removing from the SUPDL, it's no longer manufactured in CMS termed, and removing it from the MSPA. For the glatiramer 40 milligram per mil, moving it to preferred and maintaining its current PA and quantity limit and removing its generic medically necessary criteria. So again, this is going to be in the preferred spot, and then we moved its brand over to the non-preferred. Glatopa 40 milligrams per mil, it's going to move to preferred, maintaining its current PA and quantity limit, as well as removing its generic medically necessary criteria. And then for the Mavenclad, the brand, maintaining its current non-preferred status, PA criteria and quantity limit, but it will be on the preferred brand drug list, which again, I know sounds counterintuitive when it's non-preferred, but it's basically just slightly more preferred than the other non-preferred, or however you want to think of it, or the generic is more non-preferred than this one, than the brand is. All right, and then Tyruko is moving to non-preferred and then adding it to the MSPA with drug-specific PA criteria and quantity limits. Tysabri, maintaining its current preferred one-step status and quantity limits, and then updating the indication-specific PA criteria for Crohn's disease to include previous trial of guselkumab or mirikizumab. And then Zeposia, maintaining its current preferred one-step status and quantity limit, and then again, updating its indication-specific PA criteria for ulcerative colitis to include etrasimod, guselkumab, or mirikizumab as trial and failure options. And that concludes MS. Any questions or comments on the MS agents? If I could get a motion in a second, please.
Ms. Kelly, I move to approve.
This is Beth, I second.
All right, we have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta. I saw you. I lip read in that moment. Dr. Gupta. Dr. Hart.
Aye.
Dr. McCarty.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. On to the targeted immunomodulators, everyone's favorite. All right, so for Actemra, moving it to the non-preferred two-step criteria, and then updating its PA criteria to require rationale for use of Actemra over all the other biosimilar products that they now have, except for their SSC-ILD indication, since the other biosimilars don't have that indication. Abtosma, moving to non-preferred two-step, updating its PA criteria to require a rationale for use of Abtosma over the other preferred biosimilar products. For Otezla XR, moving to the preferred one-step position and then updating PA criteria to include indication-specific criteria for 6 years in age and older, and weighing 50 kilograms or more with active psoriatic arthritis, plaque psoriasis, and adults with Behçet's disease. For Rapsido, moving to a non-preferred two-step position. This is a new product for chronic urticaria, and adding to the targeted immunomodulator PA with drug-specific PA criteria. For Rinvoq, maintaining its current preferred one-step status, updating its PA criteria to include verbiage regarding trial and failure of the TNFs in whom TNFs are clinically inadvisable, and then also including verbiage regarding trial and failure of at least one approved systemic agent for Crohn's disease and ulcerative colitis indications. For Tremfya, maintaining its current non-preferred two-step status, but then adding the quantity limit for Crohn's disease and ulcerative colitis induction packs so that they can get 1 pack per 90 days. And that is all we have for the targeted immunomodulators. Any questions or comments on those? If I could get a motion and a second, please.
This is Beth. I make a motion to approve.
Kelly, I'll second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart,
Aye.
Dr. McCurdy,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
We have all ayes, so that motion will carry. Thank you. See, that was relatively painless. We made it through the therapeutics committee recommendations. So next up is the managed care updates. They do not have stats to present this round due to the shifting of the meetings, but they will be providing them in April to the board. Does anybody from the board have any questions or comments that they needed to discuss with any of the managed care folks today? Or managed care, anything that you wanted to bring up? All right, hearing none, we will move on to the next agenda item, which is new drugs. All right, Lasix on you, adding to PA with criteria, and basically the criteria is just going to be around making sure that they're not overusing the product and staying within a quantity limit. So we're looking at 6 kits per 30 days and then 1 reusable unit per 6 months. So this is another one of the diuretic products that they can place in a unit, and it provides them kind of like a constant flow of diuretic, if you will. And then the prescriber has submitted medical justification for why they need to exceed that quantity limit in that particular patient. And then Benfezia, which is a new octreotide, we're adding to the somatostatin analogs PA with criteria that the member is 18 years of age or older. They have one of the following indications, so either acromegaly, metastatic carcinoid tumor associated diarrhea and or flushing, and then or vasoactive intestinal peptide secreting tumor associated diarrhea. Reauthorization will be history of the requested agent within the past 90 days. They really decided to hit it heavy with octreotide recently, so we have several new products. So Mycapssa, adding to the same PA, then the initial authorization is that a member is 18 years of age or older, diagnosis of acromegaly, the member has responded to and tolerated treatment with lanreotide or octreotide, and then the prescriber has submitted medical justification for use of Mycapssa over lanreotide injection and octreotide injections because this is an oral product. And then dose requested does not exceed 4 capsules per day. And then reauthorization will be history of the requested agent as well as the quantity limit. And then Palsonify, adding to the same somatostatin analog PA, again, member is 18 years of age or older, diagnosis of acromegaly, member has had inadequate response to surgery and or they're not a candidate for surgery. And then the dose requested does not exceed 2 capsules per day for both the 20 milligram and the 30 milligram. And then reauthorization will be history of the requested agent as well as the quantity limit. Any questions on new drugs? If not, if I could get a motion and a second for that, please.
This is Pat, motion to approve.
Kelly, I'll second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta,
Aye.
Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Any liaison with other boards today? I think Dr. Ott, you are the one and only liaison today with Dr. Marshall out. Anything from you today?
Not that I can think of.
All right. Any-
Amanda, I just have a
yes.
question. Just to kind of, I guess it's bringing Beth up to date with some of the new changes in the law and the behavioral health medication. How is that changing things? Everything's rolling under the SUPDL, is that correct?
Correct. So we have the behavioral health agents are each on the SUPDL now as of January 1st. Those went live. So we made those changes
And
with the board in November to go live in January 1. And then, February 1st for the managed care group. So they're a month behind. So they'll be next month. And then we'll continue to review them in the cycle. So next therapeutics committee review and MHQAC will review those again, place anything that we need to place, move things around if need be, kind of like we do for the other agents in cycle. We will see clearly in February when we bring the January stats, et cetera, we're likely to see some changes in those stats since we've updated PAs and moved some things around. So we'll definitely be tracking what that looks like. I haven't heard, unless you all have, since you might hear first, but I haven't heard like extreme uproar happening in the call center. Like I haven't, and because we've had before, like some of you might remember, I know Carol does, back in the way back when we like made people step through clozapine for schizophrenia before duplicate therapy. We definitely had some uproar then. And so there definitely has been some things where we've had uproar historically, but I cannot say that we've had any significant challenges or concerns that have been to date, and we're 2 weeks in. So
okay, great, thanks.
Yes, Dr. Hart.
Yeah, to just comment on that. I have had a few colleagues that have expressed concern to me about this. That was but that was all after the law had passed. I will note that the colleagues that raised concerns to me work in private pay circumstances. So it is unlikely that their patient load would be greatly affected by this. It is something that is going to be, I think, a notable change for our field because it's something that we're not used to. But speaking exclusively on behalf of myself, not the organization that I work for, nor the organization that I represent when I speak at the State House typically, I personally am okay with this change. I think the rationale behind why the change happened makes more sense than the argument in favor of continuing the protected status that we had previously enjoyed.
Thank you for those comments. And I do think, I understand the concern, I think at the start, right? Especially when you don't know what's going to change. But I think, and I hope we've tried to change things in a way that still is very cognizant of making sure we're maintaining good access and, putting things in place that allow people to get to things that they need to get to, hopefully not too difficultly, I guess if that's really the word I want to use there. And having continuation of therapy for the vast majority of patients with the vast majority of agents so that hopefully we will have very limited kind of impact, if you will, at the start for those who are already on therapy. And then for those that are starting new, a lot of times, they could certainly provide rationale, but a lot of times there is a lot of trial and error with some of the stuff, or at least some level of trial and error or educated trial and error, right? And I think we've maintained a lot of products in different areas and ways and mechanisms to hopefully allow providers to still have a lot of flexibility. So I'm hoping that providers will still feel that way now that they've seen kind of how it's progressed versus kind of the unknown that was there before. Any other questions or comments on that?
This is Nan Kuhn. I did just want to note that OptumRx has added a status column to the mental health medications. So I think that's a really good tool for providers to kind of review when they're prescribing. So I don't know if anybody knew that was out there, but it's on OptumRx, the Indiana Medicaid OptumRx website.
Thank you. I didn't know that we had put it in there either, so.
Yeah, it was Pooja's idea.
Good job, Pooja. Thanks for that. All right, we're up to old business. Any old business? I know that was sort of old business-ish and liaison with other boards. It was probably kind of a combo there. But any other old business today that we need to discuss? All right, hearing none, we are now at new business. And so any new business from the board before I turn it over to Namrita to go through her new business, and then I'll have my new business. All right, Namrita, I will turn it over to you.
Okay, thank you, Amanda. Good morning and happy new year, everybody. My name is Namrita Yancey. I'm the Pharmacy Operations Manager here at OMPP. Thank you for joining the DUR board meeting today. All board members received an email with CVs for 2 qualified candidates who have voiced interest in both the T committee and the DUR. I'm hoping that the board members had time to review those CVs and can decide on the candidate for the T committee position today. Depending on the decision by the board, the other candidate information will be forwarded to the governor's office for the vacant DUR position. Thank you.
So to recap, I think Namrita's ask is, please nominate at least one of these candidates for T committee. And then whoever you don't nominate, if you feel strongly about the other, like, unless you feel strongly that you don't want the other candidate to be on DUR board, she will escalate that to the governor's office for DUR board. So if there's somebody you're like, do not put this person on any committee, please voice that. And if you have a preference for which committee / board a person goes to, that's the route. And Dr. Hart, I see your hand raised, so I'll let you go next.
I thank you. I support adding Dr. Whiteman to the T committee.
So I have, and Dr. Hart, I appreciate that. My only concern is the affiliation with MHA Indiana. And so I just wanted to bring that up. I agree, Dr. Whiteman is a great addition to committees. I just want to bring that up.
I think, like many of us here, we all wear different hats. I wear multiple hats myself, and in particular, I am a legislative representative for an organization who will not always be in agreement with this committee. But much as I'm able to set aside that perspective and be aware of what is the responsibility I have and the role that I'm serving in the moment, I've known Aaron to be able to do that as well.
Okay.
So I think your concern is valid, but I think Aaron does have ability to recognize that when he is doing work on behalf of MHA, he may have one viewpoint that he needs to be responsible to. And if he were doing work for the T committee, I trust him to be able to recognize that his responsibility is to the state and to the Medicaid members that are affected by those policies.
Okay. I just, from a transparency perspective, I just wanted to make sure that we had some public, we publicly discussed it so that was out there. So I appreciate that, Dr. Hart.
Yeah, no, understandable. I mean, I think that those are things to talk through, and to even to kind of directly point out to him, to just make sure that he really does. I mean, I trust him to manage conflicts of interest, but it never hurts to have a conversation with a person to make sure that they are aware that we all know there's potentially conflicts of interest, and you have to be careful about the hat you're wearing.
And to your point too, there is conflict of interest, like everybody has to, as you all probably remember, you had to do conflict of interest, et cetera, that you fill out when you join. And so we certainly, if there's somebody that has to like recluse themselves or something from a vote due to that, we certainly take that into account too. And sorry, Beth, I didn't mean to cut you off. Please go ahead.
No, you're fine. I didn't raise my hand. Has anybody talked to Dr. Whitman? Dr. Hart, have you specifically chatted with him about being able to wear those hats?
I've not personally spoken to Dr. Whiteman in a couple of years.
Okay.
So he has no idea that I'm in favor of him.
Okay.
And my comment isn't to call out MHA Indiana specifically. I mean, you're absolutely right. We do all have conflicts of interest that we have to consider. And I've always been careful for the last 20 years with Indiana Medicaid to ensure that I'm not even in any consulting positions that would draw any kind of questions about conflict of interest. What I want to recognize, though, is that MHA Indiana played a massive role in the open access statute in 2020 and 2025. Good Lord. I had a birthday, so I'm a year older, so I'm going to blame brain fog. So in 2005. So I just want to acknowledge that there is, this was the way that the open access going away last July happened was kind of, under the radar in the budget bill. And so I think that there are a lot of potential conflicts with that, and just wanted to mention that. I'm fine with Dr. Whiteman as well. I appreciate Dr. Whiteman. I've worked with him before, and so I would concur with Dr. Hart.
All right, so we have an official motion from Dr. Hart for Dr. Whiteman for the Therapeutics Committee. Do we have a second or any other conversation regarding that?
Now, I would just ask if this moves forward, that perhaps OMPP have that conversation, as they're extending the position, just to make sure he knows and he's comfortable with that.
I agree with that.
Is that amenable to OMPP? Okay, they are confirming that they are amenable to that.
Okay, this is Beth. I second the motion.
Okay, I was going to ask, was that your official second, Beth? Or
It is yes, with that caveat, please.
Okay. So the motion is that Dr. Whiteman for the Therapeutics Committee, with the caveat that there's a discussion at his approval, if you will, that you talk about the conflicts of interest, and that he feels that he is okay and willing to take that into consideration. And then if not, we can come back to the board and have that discussion. All right. With that, I will take the roll call vote then. Dr. Ott.
Aye.
Dr. Gupta. Dr. Hart.
Aye.
Dr. McCarty.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Does anybody on the board have any concerns with the other recommendation going to the governor's office for the board? If you do, please speak now or forever hold your peace.
I don't have a problem. That's fine with me. Do we need to make a motion and approve to send that for the DUR board?
No, I don't think so, because the governor officially will approve it. We just wanted to make sure there was no comments or concerns on your all's end before we send them up. So Namrita will handle that as well. Perfect. All right. Thank you all for that. We will go into the rest of our new business then. For the Elevidus PA, the label was recently updated, so we are recommending an update to the authorization criteria to meet their label, which is the member is ambulatory. And then for the epidermolysis bullosa agents, Vyjuvek updating its initial authorization criteria to remove age limit. They've recently done studies and have basically like indication down to newborns now, or itty bitty babies, which makes me so sad to think about itty bitty babies with this disease state and all of their skin sloughing off. But apparently it's a very real thing. So we want to make sure we cover them as well. And then in our non-drug specific PA criteria, so this is really just adding as a clarity point. Basically what we're trying to say in the language that is here is that if something was preferred and then moves to non-preferred, or if something was brand medically necessary and then switches, or if something's in another area and somebody was previously on it, we want them to make sure they're following all the other established limits. So I'll give an example of, let's say something was preferred and it moves non-preferred and they haven't trialed any of the other preferred agents, and they say that they can't trial any of them for whatever reason, but then one of the preferred agents has, or all the preferred agents have a step therapy to use something else. Theoretically, those individuals should have tried that step therapy even if they can't trial the other agent. So we're just trying to make sure that they're following basically all the criteria that everybody has to follow through that group. And so we're trying to clarify that language. So that's essentially what this is doing, is just making sure that they're meeting all the requirements for PA, step therapy, quantity, and age, irregardless of kind of where it is on the PDL. And then since when we got all excited about updating the somatostatin analog PA, we made some other updates just to be consistent throughout. So for the somatulin depot and the lanreotide, updating the initial authorization for an age limit of 18 years and older. And then as we were reviewing the indications and what's permitted for the approved compendia indications, there were some that didn't have the appropriate level of evidence for approved compendia. And so the carcinoid tumor of the stomach and portal hypertension are being removed from these two products. And then for the sandostatin and the sandostatin LAR, updating its initial authorization to include the age limit. So members 18 years of age and older and has one of the following indications. So the acromegaly, autosomal dominant polycystic liver or kidney disease, esophageal bleeding, chemotherapy-induced diarrhea, intracutaneous fistula, GI angiodysplastic lesions, hepatorenal syndrome, hyperinsulinic hypoglycemia, metastatic carcinoid tumor, and then vasoactive intestinal peptide secreting tumor associated diarrhea. And then if they're less than 18 years of age, then they have one of the indications. So either bleeding associated with esophageal varices, hepatorenal syndrome, or hyperinsulinemic hypoglycemia. All right, and then on the transthyretin impacting agents, Vyndaqel is being removed. So it's removing from coverage, and from the PA and age and quantity limits, they are removing it from the market. So it's not available. On the OTC drug formulary, we mentioned earlier about fexofenadine suspension being there. So we're updating the quantity limit to 30 mils per day and maintaining the age and step therapy. So just making it consistent with what's on the PDL so that the OTC drug formulary and the PDL match. And then on the nasal antihistamines, nasal anti-inflammatory steroids, this is just informational only. So there's been some really fun stuff going around about Dymista. There was apparently a news story with a picture of a different drug saying that they had discontinued their drug, which is in fact fake. They have not discontinued Dymista. It is still available, but there was a shortage. They say their shortage is resolved. However, it doesn't appear to fully be resolved. There are still some pharmacies having some issues. So we've been in several discussions with the manufacturer. Right now, we're allowing basically both the brand and generic, whatever they can access so that there's not disruption. But we are going to move it back to preferred brand status by 4/1 because since the issues are resolved with manufacturing, we believe that the stock should be fine by then. If for some reason it's not, we will come back to you and let you know that we need to continue further on. And so then again, the generic is also going to be available, as I just said. And then also in other weird stock considerations, in the topical antiparasitics, the Natroba brand, we had moved their generic, which I'd like to say is manufactured by the same manufacturer, but we're flipping it so that the brand is now preferred. They had concern,
Sorry, we had.
or both are preferred. Yeah, both are preferred. Historically, we had just the generic. They had concerns that they didn't have enough stock of the generic, which is basically just the other tube with the other name because they manufacture them both. And so we are now having them both allowed, and they have provided financial considerations so that they are both the same price. So for us, it doesn't matter which one people use. So that's what we are updating to that. All right, and then as far as our preferred brand drug list updates, additions to the preferred brand drug list include Cipro HC, Odex suspension, Dymista, we mentioned will be 4-1, Mavenclad tablets, and then Spritam tablets, and then removals from the preferred brand list will be Bethkis, Neb solution, Capaxone 40 milligram per mil, Hetliaz capsules, and then the Xarelto 2.5 milligram tablets. The suspension will remain on the preferred brand list. All right, any questions on any of those new business items? I know that was kind of a lot.
Just a quick question.
Yeah.
So Dymista and Azlastine, the generic, they're not manufactured by the same.
They are not, no.
Okay. So there is a price difference.
There is currently. So, and I couldn't tell you how significant that price difference is. We could look that up and see, but in general, if there's not availability, then we do try to switch it over to the generic and have allowance there. But we can definitely look at that too. Yeah, no worries.
Yeah, it was significant enough to move it back. To put it back on the branch.
Oh, yeah. Okay. Any other questions? All right, if I could get a motion and a second, please.
So moved.
Second.
All right, I have a motion and a second. Dr. Ott,
Aye.
Dr. Gupta, Dr. Hart,
Aye.
Dr. McCarty,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Next up, we do have 2 items of public comment, and so I'm going to hopefully get my clock here. Here it is. And so first up on our public comment is Dr. Patel with Sarepta.
Yes, good morning. Can you hear me?
Yes, we can.
All right, thank you. Thank you for the board for allowing me to speak and addressing the Levitas of a new policy. So my understanding is the change you just made is to cover and Levitas supported the policy that is consistent with the label, the new label, which is only for 4 years of age and ambulatory. So knowing that, unless there are questions from the board, since the label is consistent with the policy is consistent with the label, I don't have any further remarks unless there are any questions.
Any questions from the board? All right, thank you, Dr. Patel.
Well, I appreciate everything you do for this policy in the DMD community. Thank you very much.
Thank you. Next up, it looks like we have Brian Denger.
Good morning, that's correct.
And you are welcome to begin whenever you're ready.
Thank you. I'll be equally as brief. I work for Parent Project Muscular Dystrophy and Community Engagement, and I support the changes that were made and appreciate continuation of coverage of Levitas to patients, eligible patients with Duchenne muscular dystrophy. I also have a 31-year-old son who has Duchenne. He's treated with a targeted muscular dystrophy therapy, and it has been beneficial for him. He's 31 years of age, continues to be able to use a cell phone, computer, and feeds himself. And I think that the small gains that we get from these therapies is really consequential. I also want to point out a recent report from the EMBARK trial was published in Neurology and Therapy, showing a 2-year data for stability and slowing of progression in patients treated with Levitas. and appreciate the board's supportive coverage for appropriate patients. Thank you.
Thank you. Any questions, comments from the board? Thank you both very much. With that, then, I think we are now to the end of our agenda and at adjournment. Dr. Ott?
Yes, thank you everybody for attending and for the great conversation. And I will adjourn the January 2026 meeting of the DUR board.
Thanks, everybody. Have a great weekend. Stay warm and try and stay out of the snow, unless you're building a snowman.
Take care. Thank you.
Bye.
Thank you.